Carbonic anhydrase inhibitors work in proximal convoluted tubule, where they inhibit enzyme called carbonic anhydrase. This enzyme is important for the absorption of bicarbonate ions and sodium ions. Let's understand what happens in PCT. In proximal tubule cells, at the basolateral membrane sodium-potassium ATP transporter pump 2 potassium inside the cell and 3 sodium outside the cell, decreasing the sodium level inside cell. Now there is a sodium and hydrogen antiporter pump at the apical membrane. Through this sodium present in the filtrate move into the cell toward its low concentration in exchange of proton. Now this proton combine with bicarbonate ions present in filtrate and form carbonic acid. Carbonic acid breakdown into carbon dioxide and water. This breakdown reaction occur in the presence of enzyme present at the cell membrane called carbonic anhydrase. Carbon dioxide will be absorbed back to the cell, where it combine with intracellular water to form carbonic acid in the presence of carbonic anhydrase inside of the cell. Carbonic acid breakdown into protons and bicarbonate ions. Bicarbonate will be absorbed into blood at the basolateral membrane in exchange of chloride ions, while proton will be exchanged for sodium to start the cycle again. Now carbonic anhydrase inhibitors will inhibit this enzyme, inhibiting the breakdown and formation of carbonic acid both in lumen and inside the cell. Even if carbonic acid form in lumen, it will not be breakdown into carbon dioxide and water, hence can't be absorbed, and then no proton will available to absorb sodium from filtrate, decreasing proton secretion in lumen. Hence bicarbonate, sodium will be excreted, and as water tend to follow sodium it will be excreted as well. As you already know, carbonic anhydrase inhibitors doesn't directly inhibit sodium absorption, it inhibit the enzyme, causing excretion of sodium but more excretion of bicarbonate ions as compared to sodium ions. Due to decreased level of bicarbonate ions in blood, it cause the pH to decrease and become acidic due to increased protons level in blood. This lead to a condition called metabolic acidosis, which is due to kidney issue not because of lungs. This is not due to anion gap, so it's called non-anion gap metabolic acidosis. Decreased pH activates central chemoreceptors in the ventrolateral surface of the medulla oblongata. This stimulation is not due to hydrogen's ion as they don't cross blood-brain barrier, but carbon dioxide can cross. Once in the cerebrospinal fluid, CO2 reacts with water to form carbonic acid, which lowers the pH, activating the receptors. These receptors increase the respiration rate and depth of respiration with overall increase in tidal volume. This cause more oxygen to be inhaled and more carbon dioxide exhaled. Decrease carbon dioxide shift the following reaction and remaining more proton now react with bicarbonate to produce carbon dioxide that lead to decreased proton level in blood. Now this lead to a condition called respiratory alkalosis, increasing pH of blood and compensate the metabolic acidosis caused by carbonic anhydrase inhibitors. Drugs belong to this class is acetazolamide that can be indicated in altitude sickness, where there is less oxygen and body respond by hyperventilation. More carbon dioxide is exhaled, more proton shift reaction to form CO2 causing respiratory alkalosis due to decreased proton level. Now acetazolamide will compensate this respiratory alkalosis by causing metabolic acidosis and decreasing bicarbonate ions in blood. This metabolic acidosis further stimulate the chemoreceptors, increasing respiration rate and depth. Acetazolamide can also be used to treat glaucoma, where it decreases the interocular pressure. In glaucoma, there is increased aqueous humor production that increase interocular pressure. High interocular pressure can damage optic nerve. Carbonic anhydrase forms bicarbonate inside ciliary epithelial cells of eye. Bicarbonate is actively transported into the posterior chamber of eye, where sodium also follow it, and then water follow sodium forming aqueous humor. Acetazolamide inhibit the enzyme and hence decrease aqueous humor production. It can also be used in idiopathic intercranial hypertension, which is the condition caused by high cerebrospinal fluid production without a disease or tumor. Here it inhibit carbonic anhydrase and decrease bicarbonate production that draws sodium and water in cerebrospinal fluid. Its adverse effect include metabolic acidosis due to excessive bicarbonate loss and increased proton level in blood. It increases risk of kidney stone by increasing pH of urine. In alkaline urine, calcium phosphate precipitate, forming stones. It decrease citrate level in urine, which normally prevents stone formation. It cause hyperammonemia. Ammonia is neutral molecule and can be absorbed from filtrate easily. As it combine with proton forms ammonium, which is charged molecule and can't be absorbed, hence get excreted. As proton is not secreted in lumen, no ammonium is formed and excessive ammonia will be absorbed. It cause hypokalemia. As maximum amount of sodium that is not absorbed in proximal tubule reached distal tubule, it will be absorbed in exchange of potassium that will be excreted in urine.